Good afternoon, everybody. مساء الخير الجميع. It's my pleasure to be with you today to discuss the topic congenital glaucoma as an update. You know, it's a major pediatric health problem in our community, unfortunately, and this is will go over it and why we have such a health problem in pediatric group in our community it will come during the lecture. So what I will do, I will go for just short definition, classification, clinical picture, differential diagnosis, which is very important, incidence of the disease and pathophysiology and treatment. What is the status of the conventional surgical therapy? Is there any other new techniques? Is there, and we'll share you some of our experience in managing the congenital glaucoma in general in our facility here at King Abdulaziz. Then we'll conclude what is our responsibility in dealing with this disease. So the definition, the congenital glaucoma defined as a defective development of structures in and around the anterior chamber angle that result in impairment of the aqueous humor flow, resulting in an increase in the intraocular pressure, giving us what we see it as clinical findings: ophthalmos, large cornea, corneal haze. Yes, Mona, huh? Okay. And I don't need to see myself. I can see myself in the mirror. So this defective development in the outflow system, which is congenital, or as when we come to the pathology, there is no exact or precise pathophysiologic knowledge about it. So this will result in increase in the intraocular pressure, leading to what we see as clinical findings or signs of the disease. So, and usually it occurs congenital glaucoma within the first 3 years of age, from birth to 3 years. Then it's classified again, congenital glaucoma, into primary congenital glaucoma. As you will see later, it is represent the bulk of the cases, at least in our community, and it is represent an isolated trabecular dysgenesis with no ocular or systemic association, usually diagnosed, as I said, at birth or shortly thereafter. And most cases are presented within the first year of life. However, sometimes the symptoms are at least not recognized until late in the childhood period. Then the second division of congenital glaucoma, based on the classification, what we call it secondary congenital glaucoma, means cases that occurs in association with ocular or systemic abnormalities. So then again, for more or further discussion with the family and to know what is the prognosis of the disease, the primary congenital glaucoma divided again into 3 categories. The primary newborn congenital glaucoma represent those cases which diagnosed from birth to the first 1 month of age. And it is known to be the most severe type due to the severe anomalies in the anterior chamber angle outflow facility. Then it comes the primary infantile glaucoma. This carries the best prognosis and usually diagnosed between the age of 1 month and 3 years. And then it comes the primary juvenile glaucoma, which is diagnosed after 3 years of age. Somebody will even, they say, after 2 years of age. Anyhow, so what are the symptoms of the disease of congenital glaucoma in general? Usually ebuphora, excessive tearing, photophobia, and the blepharospasm. The child most of the time closing his eyes because he cannot tolerate the light. And the signs, the signs, okay, no. The signs are, it's covered here, and let me see. It's, the signs, yes, it's usually you find, although the measurement of intraocular pressure, to have a good measurement, you need a calm or quiet child that can be achieved through either general anesthesia or sedation if he's more than 3 years or 3 months, or through fasting the child for 3 hours or so, and then you give him his meal, and then you can do most of your examination in a quiet way and very reasonable way. So increased intraocular pressure, ophthalmos, large globe, megalocornea, corneal haze or scarring. Sometimes it is not that common in our community, at least half stray due to rupture of this membrane, and optic nerve coupling if the view is enough to visualize the posterior segment. This is, of course, congenital glaucoma can be unilateral, as in this case, or it can be bilateral, as you see here. Unilateral in 1/3 of cases, usually unilateral. Majority of cases are bilateral, as you see in this child. So it can be unilateral and can be bilateral most of the time. Once we have the clinical picture, the symptoms and signs, then we need to put in mind what things that are conditions that can or mistaken as a congenital glaucoma, or we need to differentiate it from other conditions that could be or have similar findings in some aspects. So, for example, large globe ophthalmos, this can usually be associated with axial myopia, large globe, retrobulbar mass, or shallow orbit, blue sclera, connective tissue disease, large cornea. This is very important. Simple megalocornea, although simple megalocornea, most of the authorities consider it as a part of the spectrum of the congenital glaucoma. So simple megalocornea, such a condition, you need to follow the patient for the rest of his life. He might develop glaucoma any time, corneal ectasia and so on. So then descemet tears and the bands, birth trauma, we need to differentiate between the habstria and birth trauma. Each one of them, they have its characteristic. Usually birth trauma, usually vertical linear breaks in habstria, usually can be linear with the limbus. Posterior polymorphous corneal dystrophy, and of course, this is usually birth trauma, usually forceps delivery, and so on. And other causes of endothelial infection, rubella, syphilis, brittle eye syndrome, hypotony, and these things. Yeah, and it is not that difficult to figure out the real congenital glaucoma from such conditions. Corneal haze or scarring. Here, the most common thing that I have seen it in my life, that many cases of congenital hereditary endothelial dystrophy has been operated as a congenital glaucoma. Although when you look to the literature, you'll find that there is some sort of report talking about, although it is weak, like some sort of association between the CHED and congenital glaucoma. Posterior polymorphous corneal dystrophy, again, and when you go to congenital hereditary dystrophy, yes, the cornea is really similar or resemble the cornea and to some extent of congenital glaucoma, but there are lacking other signs of congenital glaucoma. And again, also this haziness or this thick cornea also, it has its particular features compared to the one in congenital glaucoma. Congenital stromal dystrophy, posterior amorphous, I haven't seen such things, but it can be, this is what has been. Mucopolysaccharidosis and other storage diseases, again, we need to put it in mind as a possible differential diagnosis. Corneal haze and scarring, Peters anomaly, sclerocornea, and optic nerve cupping, again, can be mistaken. Some certain types of optic nerve cupping can be mistaken as a congenital glaucoma, for example, physiologic cupping. Babello-renal syndrome, haven't seen it. Optic nerve hypoplasia, yes. Optic nerve coloboma, yes. Morning glory abnormality or syndrome, optic nerve pit, all these. But again, yes, you may suspect or you have be in a suspicion that this disc is a glaucoma. Yes, but again, you will see no, you will not find other signs of the disease from the corneal side, from size of the globe, from the pressure-wise, and so on. So, but you need to keep these in mind that could be mistaken as congenital glaucoma. What the disease prevalence in our community? Actually, there is no exact or precise studies that tells us what is the what they call it the load or the incidence or prevalence of the disease exactly. There is no, as far as I know, field studies that telling us what is the incidence and of the disease in our community. But it is, when you look to the literature, it is very rare in Western countries, from 10 to 20,000 live births, and in our community in the Middle East, estimated to be 1 in 2,500, and we are almost coming behind the Rome population of Slovakia, where the disease is the highest prevalence in the world. And it is reported to be congenital glaucoma is the most common cause of childhood blindness in our country and visual impairment, unfortunately. So again, the disease inherited or in most cases in sporadic occurrence in Western countries, and inherited in our country in many studies that as an autosomal recessive pattern. So again, this is tells us why the disease is very severe in our population. Mechanism, as I told you, many reports talking about abnormal thickening of trabecular beams, loss or absent intertrabecular spaces between needle layers of trabecular meshwork at the level of juxtacanalicular meshwork, presence of anamorphous material, again, in the subendothelial area, juxtacanalicular, of Schlemm's region, I mean, a little bit before Schlemm's canal, and totally or partially absent Schlemm's canal, especially in newborn type, which indicates the severity of the disease. Again, I remember when we were in the medical school, early in the residency and so on, they telling us or teaching us that there is a Barkhan's membrane. Where is the Barkhan's membrane, which is a an imperforated membrane in front of the trabecular meshwork, and this is the cause, and this is why Barkhan's in the mid-40s he invented the goniotomy, aiming to cut that membrane in front of the trabecular meshwork in the mid-40s. But until now, histologically, as well as with the electron microscopy, nobody could confirm the presence of imperforated membrane in front of the Schlemm's canal, in front of the trabecular meshwork. So again, the latest pathophysiologic findings in the anterior chamber angle of the newborn primary congenital glaucoma, they found that major histologic findings are partial absence and retro displacement of the Schlemm's canal, as well as hypoplasia of the trabecular meshwork and broad attachment of ciliary muscle to the meshwork, and there and anterior insertion of hypoplastic iris with the formation of pseudomembrane. Again, this is probably why I say that there is no very precise explanation or understanding of the exact pathophysiology. Could be multifactorial or whatever, as they mentioned. Anyhow, so it is a disease in the angle. It is a problem in the angle. So treatment, when we look to the literature, you will find that the treatment consists of either goniotomy. This is since the mid of the or the 40s last century. Trabeculotomy also in cases where there is no good view to see the angle through the cornea. So trabeculotomy, you go and cut the trabecular meshwork from external approach. And in the late, probably, or in the early 90s, the surgeons start to combine the trabeculotomy with trabeculectomy, hoping this will improve the surgical outcome. And I remember, in my residency, we were doing trabeculotomy, little goniotomies, because most of our cases are having some sort of corneal haze, and most of the time, trabeculotomy is the primary procedure in congenital glaucoma. Then we convert to combine trabeculotomy and trabeculectomy, hoping this will improve. And this is, as you will see later on, it has its advantage over trabeculotomy from surgical success rate point of view. So in overall, the goniotomy, trabeculotomy, and combined procedure, usually giving a success rate between 30 and 90 based on the size of the series reported, the duration of the follow-up, and probably the type of population, but we'll see more. So in goniotomy in general, overall success rate at 12 months follow-up has been found to be 72 with single goniotomy. This is in Western population. And this figure, or this percentage, goes up to 90 with more than one goniotomy. In Middle East and Africa, as we'll see with the Dr. Hazmi paper soon, they found that 50% in Southeast Asia and Africa, as well, even Africa less, and Middle East. So the goniotomy in our population, the outcome is not that encouraging as in Western population, and this is again related to the type of the pathology. We have a more severe pathology than what's happening in Western population, and this is has its probably some explanation regarding the type of inheritance, the type of glaucoma. We are having more newborn type, which is having the or being more the severe type, as well as in Western population, most of the cases are in a primary infantile type, which is diagnosed after 1 month up to 2 or 3 years. So what is the literature says about trabeculotomy? When you look here, if you excluded, I think, France, here from France, yes, and Hazmi study, as you will see it later on, most of the study are, the overall success rate is comparable, yeah, ranging from 70 to, say, 90 or so. But again, the success rate governed by the size of the series, by the follow-up period, and so on. So when we go to the combined procedure, again, you will find Saudi Arabia, there are two. One of them is a Hazmi study, as we will come to it later on. And again, the overall, you see it here, it's comparable in all different population, different hands, different whatever countries. The overall success rate is almost comparable. So let's go, the upper success rate is about, in combined procedure, is 70 to 80% at 12 months follow-up. And when we compare, this is the study that you need to read it very well. This is the best study has been reported from our country regarding the conventional therapy in congenital glaucoma by Hazmi and his colleagues, reported in the British Journal of Ophthalmology in 2005. And retrospectively, with the limitation of retrospective studies, they classified the cases into mild, severe, moderate, and severe based on the size of the cornea, the level of the pressure, as well as the corneal haze, degree of corneal haze, into mild. And they found that in mild cases, of course, this is going to be probably before we started the combined procedure. So they found that in mild cases, whether goniotomy or trabeculotomy, the success rate almost similar. But when we come to the moderate cases, you find the differences between the three procedures. About 13% success rate in 109 cases, and up to 40% in goniotomy, and up to 40% trabeculotomy, and 80% in 70 cases. Again, with my reservation and observation about the goniotomy in moderate cases, when we are teaching colleagues, junior colleagues, we are saying that goniotomy, you need a crystal clear cornea to do it. I don't know my colleagues who did this at that era of time. They did it on a moderate cases, probably, and assuming that probably the cornea was clear enough to let them do the surgery. Anyhow, so in severe cases, when we come to severe cases, no goniotomy because of the poor corneal view. And again, the trabeculotomy, the success rate is very low, 10% compared to 70% in combined procedure. And when we look at the total, as in other reports regarding the success rate of goniotomy in other areas of the Middle East, as well as Asia and so on. So it is 50 to 52%. It is, again, a little bit poor, still, poor in the trabeculotomy and giving the best results with combined procedure, 75% as our overall success rate. So this study is very good. You need to read the article. It's very beautiful. And the complication, of course, you can go over the complication. These procedures are not complication-free, and there is no procedure which is complication-free, but the rate of complication and the severity of complication differs from procedure to another. Then, so what is the new in the congenital glaucoma surgery? A newly emerging surgical technique like viscotrabeculotomy or viscotrabeculotomy. The outcome report are scary and not much, but they are claiming that it is a little bit better, but it is not significantly, there's no significant differences. Endoscopic goniotomy, it's still, there's a small report saying that goniotomy in endoscopic goniotomy in cases where their cornea is poor view, so you can go through the endoscopic procedure. But again, I believe the pathology is not just to cut a membrane in front, or what is supposed to be a membrane in front of the Shen's canal, the trabecular meshwork. Then the sclerectomy, we'll talk about it more, which is now evolving in the Europe, Asia, and in the Middle East. Dr. Franz Gren wrote a letter to the editor in, I think, Journal of the British Journal of Ophthalmology. What he's saying that the conclusion that he said that the disease is different from a nation to another, and being most severe in Arab world or Middle East, and the prevalence also, or this is much more common, about 10 times in our area compared to the Austrian population. And what he says that we are not, the congenital glaucoma surgery is a neglected field in ophthalmology, because the rarity of the cases in Western and so on, but the situation is not as in our community here or our area. So people are not interested, probably because of the rarity of the cases, to develop new procedures. So, and he talked about the importance of forming a center of excellence to deal with the disease from its different aspects, as we'll see later. So what he wants to say that, yes, the disease is neglected. The surgery in congenital glaucoma is a field which is neglected by many of us. So what is the deep sclerectomy? What has been reported about the deep sclerectomy results in congenital glaucoma? There are 6, I think, or 7 studies. If we removed one from Germany by Luke, where his cases were actually not suitable to do, when you read the article, is to do a deep sclerectomy in these cases. So when we look to the to the rest of the studies, when you look to the overall success rate is again similar, as you will see later on, and the outcome is good. So based on that, we determined to see the efficacy and safety of deep childhood glaucoma. This was started in early 2001 or 2000 even, and we reported this. I will go just over it in the our cases, 143 cases of 120 patients, the mean ages and so on. And the majority of cases, this is very important here, majority of cases where primary congenital glaucoma, more than 90% of our patients are primary congenital glaucoma. And almost 87% of them, of the newborn infantile, the primary newborn congenital glaucoma, the severe type. So anyhow, so what is important to us, the exclusion criteria for us was previously operated eyes. So we can accept in this report, we did in primary congenital glaucoma as well as in secondary congenital glaucoma. But we excluded only any case. So the procedure was as the initial procedure in these eyes. And then the success rate, as you may read it in many reports, an intracup pressure more than 6 and less than 21 without medication, the qualified success equal or less than 21 with typical medication, and failure those beyond that. So, and our procedure is unique. You know, this is a patient, one of our cases with stage Roper syndrome. I brought this stage Roper syndrome because, again, probably I think I can comment on one thing that regarding the stage Roper syndrome. You can see the cautery marks and so on. So we'll see it's a short review. You can create the superficial flap. This is stage Roper syndrome with congenital glaucoma. You create the superficial flap, and then you can see all these are new vessels, cauterized, new vessels. It's a lash of a plexus of a new vessel. Since we created the superficial flap, then we go, and to be careful, these eyes, although stage Roper syndrome probably is thicker than in primary congenital glaucoma, but we need to be careful in the preparing the second flap because the wall is usually, these eyes are ophthalmic and the wall is a little bit thinner than normal patient. So here, when you see now we created or you expose the intraoperative meshwork. This band is border section, this band. But you can see when we expose the Schlimm's canal, you know, the oozing. Why I want to say that? I am choosing this video. You know, in stage Roper syndrome, there are many reports regarding what's the pathomechanism of glaucoma and stage Roper syndrome, and many say that they classify it into congenital and children above 3 years or so, and they say that the mechanism is different. And many authorities, they believe, big authorities, they believe, and as I do also from our limited experience, that the problem is not in the not in the angle. Not in the angle, no, not in the angle. So it is beyond the angle. It is beyond the angle at the level of the image clavius plexus. So once you remove the floor, the roof of the Schlimm's canal, you can see oozing of the aqueous humor. The angle hasn't been, or the trabecular meshwork hasn't been cut or so. So this is very important. Okay, so the outcome, you know, the follow-up, the results as follow-up after almost 3.5 years, the minimum follow-up is 6 months up to 10 years, the IUP reduced from 31 to 16 millimeter with a very significant p-value, as well as, which is important to us, not the number of medication, but the corneal haze. Corneal haze is a major issue in the development of the or preservative development of the vision or visual pathway. You need a clear cornea to develop the vision in these young children. So the corneal haze from 2.1 to 2.57, which is again a very big or significant p-value. So this is very important. IOP, and of course, resulting as a result of introducing the IOP, the cornea will clear up if the corneal edema and haze has not reached the stage of scar formation and so on. So this is very important. So what are the complications? When you read the complication among the conventional therapy that reported by Dr. Hazmi, you'll find here, and this is a prospective study, by the way, there was no intraoperative complication. The things that might happen, perforate, micro or macro, which is not a big deal. Still, you have the advantage of deep sclerectomy. Shallow AC in 4 cases and hyphema in 2 cases. And there is a late complication, late sclerectasia. But when the child growed and we were able to look at him in a better way, that was not ectasia. That was the iris relapsing under the sclera flap. I don't think you can say it is ectasia. So, yeah, so the outcome, the complete success was achieved in this study in 117 out of 134. That means almost 82, with a minimum follow-up 6 months and maximum follow-up is 110 years. And to my knowledge, there's nothing greater or achieved in our area with such a success rate, and overall success rate is 86. So this is very important. And most of the failure occurs within the first 6 months. So let's give it. Yeah, what we found that the variables that may affect the outcome of deep sclerectomy in this series was the degree of haze. Degree of haze is probably the important factor, risk factor for failure. And when we compare it to the studies that dealing with our real deep sclerectomy in a good eyes, we can find by the one from Denmark, by Oliver, where he did 30 cases and we did 143. And you can look here, the success rate, the overall success rate, and even complete success rate is comparable. Different pathology, different hands, but still the procedure, you can predict that the outcome will be very good. And then, yeah, and if we look or compare it to the conventional therapy, this is again by us, a prospective study, even masked, and this is prospective, and trabeculotomy done with mitomycin versus no mitomycin in 22 eyes, 11 patients in each arm. And when we found the complete success was 45% compared to 82 almost. So it's superior to trabeculotomy definitely alone, but I'm not saying to combine. And this is the, if you want to read more about this article, it is written in the, or published in the Ophthalmology in 2012. And this series reported in, or discussed, or presented by us in American Academy in 2011, I think, or so, before publication of this report. So we concluded from this report that deep sclerectomy is effective with high safety profile in congenital glaucoma. As well, it is worthy to be the first surgical option in this disease, and higher degrees of preoperative corneal haze is a risk factor for failure. Based on that, and when we presented this study in the American Academy, the panel for discussing me after when I finished the presentation, they said you need, with this high prevalence or incidence of the disease, probably you need to compare it to a conventional procedure, the trabeculotomy, goniotomy, or combined. At that time, I didn't tell them that we already started this project, deep sclerectomy versus combined trabeculotomy and bilateral primary congenital glaucoma. So this we started before we discussed this issue or this study with them. So our rationale to make really a solid impression about the deep sclerectomy, we need to do such as a study. And so our rationale is, although deep sclerectomy has proven its efficacy in congenital glaucoma, there is still a debate about its ability to the combined procedure, and there is a need to provide a concrete evidence of this issue. And the best of our knowledge, nobody did a study comparing the two procedures, whether retrospective or even prospective or clinical trial as we did. So our objective to compare the efficacy and safety of both procedures and to detect the rate and types of complication in both groups and to improve guidelines if there is a room for that for the management of congenital glaucoma. And this is the sheet I will not reduce. Our, again, major outcome measures is reduction of IOP, reduction in Hayes scale, reduction of the number of anti-glaucoma medication, improvement of the coupling if it is has the aroma over that, and reduction of Hayes in corneal, and then the corneal size, and a difference in success rates, as well as rate and time of complication. And methods, majority of congenital glaucoma cases present, as I said earlier, as bilaterally affected. The child's right eye has been designed to have the sclerectomy and left eye for combined procedure. And exclusion criteria or exclusion criteria were secondary congenital glaucomas, not only primary ones, bilateral ones, previous surgery again excluded, and excluded unilateral cases. So this is presented in Spain in one of the meetings when we finished 106 eyes of 53 patients. But now we are reaching more than 80 cases, about 160. We are waiting to find how we can write this paper, which will be a very important one. So what is the findings? I will skip this one. And this is the complete success as the and the other study. And this is presented again, this one in Scotland, and they like it very much. This is a primary combat. They're showing them the deep sclerectomy and trabeculotomy in congenital glaucoma. In Scotland, this is many years ago, I think 4 or 5 years ago. And you see deep sclerectomy after the deep flap, you can see the oozing, beautiful, beautiful. This is what you need. All you need here now is just to remove the sclera flap and a deep flap and just loosely close the superficial one. Sometimes we use implant, sometimes we use using Kaplan only to fill the decompression space to prevent accumulation of fibrin and blood there, so minimize the scarring. This is the deep sclerectomy. And then it comes the trabeculectomy again, very quick. Probably you're not frequently now seeing this procedure, at least in our facility here, because most of the colleagues are shifting now to deep sclerectomy. So even as a first procedure, second procedure, so we are bypassing this combined procedure. So we do 2 deep sclerectomy, then later we may employ tube surgery. So first we create a superficial flap, then we look for the Schlemm's canal blindly here, expecting this is its place, as you will see later. Anti-matamycin is used in all cases, and yeah. So here we are creating the trying to find the Schlemm's canal, and we trying to verify is this Schlemm's canal bypassing cycloproline suture should go with ease, but again you are not 100% sure. Now if you are in the Schlemm's canal or not, I know my colleague Dr. Jadaan now, or they reported in the process of publishing their results using a lighted probe or microcatheter, sorry, to canalize the canal 360 as second procedure or third procedure. We know that there is another report from Taiwan, I think, from Far Asia, discussing the outcome of 360 trabeculotomy using lighted catheter, or yes. So once you are feeling that you are in Schlimm's canal, then you can use the probe, the Barkasma, is it Barkana? Well, I forget it, to insert this probe in the Schlimm's canal and then move it, sweep it anteriorly, to cut the Schlimm's canal from external. Yes, so this is it. We've forgotten even the name of instrument because we are not doing it anymore. Then the other side, you go to Schlimm's canal, looking to the your probe, not to go posteriorly, or that. Then sweep it anteriorly, and then you create the trabecular opening here and close the flap in a good way. You can put here if you like under the flap or so. So this is the procedure doing the peripheroidectomy, and this is the procedure. So what is the outcome? The overall now, this is still, we are not, analyzing the whole cases. We in the deep sclerectomy group, we got 78 as a whole success rate, and overall success rate 87, and here 60 or 61, and overall 73. So there were no, the complete success was comparable. The p-value was insignificant, whether between the two procedures, whether as a complete success or overall success rate. And when we looked at the complication, as you see here, in deep sclerectomy, the complications are very limited here, and there is no serious complication, as you see here. While in the combined procedure, the complications are serious, and as you see here, the rate is high. So this is a very important and a gimmick for the deep sclerectomy in congenital glaucoma. So in summary, we conclude that congenital glaucoma is a major cause of visual impairment and blindness in our country or in the community, and deep sclerectomy has proven its efficacy and safety compared to conventional surgery, and is highly recommended to be the first and probably and second procedure surgical option in management of glaucoma, congenital glaucoma. And in summary, I'm finishing now. Since we have one, and we need to encourage my colleague, now I will not say junior, but younger than me, that since we have one of the highest incidence of congenital glaucoma in the world, we should have a good strategic plan for the control of the disease. We need to be like at least Western population. We need an incidence and prevalence rather than operate on bona fide cases only, sometimes at a late stage even of the disease. So what we need to do that, we have, having this knowledge, we are so negligible toward our community in terms of the following: implementation of community health education programs to increase the awareness of this disease in our community, assessment of the accurate figure and risk factors associated with the disease, conduct an epidemiological studies. And I know that registry has been started in KCASH, but I don't know how much they reach now. Identify and serve the groups at high risk to vision loss because of the congenital glaucoma, and conduct basic and clinical research to find and or develop immunotherapeutic and surgical techniques to combat the disease. And what can we do? I'm sure, if I'm young, I'm telling my sons and my colleagues, younger colleagues, that if I'm now in this situation and young, I will be able to contribute to my country. I will make my life just for congenital glaucoma. Really, I will find a looping or whatever, and so to do something for our community. Developing a mechanism for early detection and referral of cases to tertiary care hospitals, provide training to local care providers to enable them to detect and primarily treat or refer these cases, and genetic counseling of families with history of glaucoma. And we are doing this for about the last few years. And we reported a lot of report on that, but still we couldn't add much from genetic basis to what has been reported. Again, building a national database for congenital history. As I told you, this is already starting KCASH as far as I know, but I don't know where are they now. And provide assessing service to affected families and individuals, and implement rehabilitation programs to those who partial or total lost their vision. So there is in general, there is a bad need to establish a center of excellence, really. Now they are planning, they are asking in Germany, they are having 70 cases in Europe probably or per year, and they are looking for a center of excellence to deal with this disease for the whole Europe. That covers all such activities and standardized fashion. So then a glaucoma center of excellence would imply epidemiologic arm, clinical and surgical service arm, basic science research arm, as well as community health education and community-based activities arm, the outreach assessment intervention and training arm, and rehabilitation arm. Yes, of course, at this point, I would like to thank you and stop here and hear if there is any comment or questions in this regard. I'm ready for it. Thank you very much. Okay, you hear me, Ali? Ali, anybody? I'm talking to myself.
No, you talked to a large audience here. It was great lecture.
Okay, thank you very much. This is Dr. Conrad or who?
Yes, it's Dr. Conrad. Yes, thank you.
Nice to hear you.
If you allow me to say something again,
sure.
I think that really you present the right data on this. In Western world, we only have one case out of 20,000 live births compared with the incidence that you have here, 1 out of 2,500. And that leaves Saudi Arabia as probably the leader country to talk about congenital glaucoma, not only because of the high incidence, unfortunately, that you have, but also on the good way you do the things. You show us to the rest of the world how deep sclerectomy is a good surgery in such a cases, which is great. We didn't know. In Europe, we do a lot of deep sclerectomy in adults, but we don't do it in children. And you show us that it's an excellent surgery. I really appreciate this wonderful talk that you gave us. It was an absolutely great update. Thank you very much, Dr. Saleh.
Thank you, Dr. Conrad. Thank you for your comment. Any questions? Well, any other questions? Or comment?
Can I ask one question, Dr. Saleh, please?
Sure.
Assalamu alaikum, Dr. Saleh. MashaAllah. My question is, this procedure, مثلا, deep sclerotomy failed or combination procedure failed. What the next step?
Yeah, good. Usually, as I said, deep sclerectomy failed. First deep sclerectomy, and there will be a thesis will be presented by Dr. Khalifa, Muhammad Khalifa, regarding a long-term outcome of deep sclerectomy in congenital glaucoma at KSU. Yes, it failed first time. I'll repeat it next time. Actually, I don't do anymore combined procedure. Why is that? Sorry. Sometimes in severe cases, I may go from the beginning to penetrating deep sclerectomy, and to get the benefit of the other facility or other advantage of the deep sclerectomy, like the routes of filtration and so on, and to minimize the possible complication, especially major complications. Then, so first one, I'll go for a second one. Then if it is failed, probably I will shift for tube surgery. So I would like to say that I'm not doing combined procedure, except sometimes for teaching my fellows or so to know what is combined procedure, how can we do it. So only for fellows to teach them as a procedure. Of course, after teaching them the deep sclerectomy. Yes.
Mm.
Mm-hmm.
The role of Dr. Q incubation valve, Ahmed valve, or like this one, is any role in congenital glaucoma?
Again, the question, Ahmed Blant, what?
Yes. يعني if it's fair, if you can transfer, يعني the second procedure will be Ahmed valve.
Yeah, as I told you, two deep sclerectomies. For this reason, always when I do the first procedure, I use one of the quadrant, severe quadrant, not put it in the 12 o'clock. Then I do another one, which is very rare. I found myself to do such. Then a tube surgery, a third procedure, failed. Another tube surgery. Probably I will go for third tube surgery before I go to the cyclodestructive procedures. I hate cyclodestructive procedure, honestly, very much, unless in a blind or, very poor visual potential. So I'll utilize probably 2 or 3 tubes before, sometimes I might go for 4, before I consider any cyclodestructive procedure. So I'm not in favor, or even I know that there are some colleagues or whatever, worldwide, they even implement or employ the cyclodestructive procedure, especially with the microvalves, with CBC and these things, as a primary procedure. I'm not in favor of that at all. I'm not in favor at all, really. And when I see such a thing, I become disappointed. This is my comment in this regard. Yes.
Thank you very much, Dr. Saleh.
Sure.
Jazakallah khairan.
Allah yabarak, yeah. Yes, another question or comment. Mona. Yes, please. Any comment or question? Come on, where are the residents? Lecture is for residents. And I don't hear any one of them. Probably they sign in and they want to sleep. I want to hear some of them, even without a question.
Yes, Doctor, with you.
Who is this?
Sheikh Adosari, R2 Kekish.
If you have a question, otherwise, but I want to know that you are here. Mona. Yes, Sheikh, I have a question.
No, we're here. Just to say we're here.
Yeah, I want to see who are with us from residents, How can I know that, I want to see, who are there, I don't see.
Assalamu alaikum, bro.
Salam. Yes.
ما قصرت محاضرة well informative structure الله يسعدك.
مين معي؟ Why my picture just appears now? Me and Conrad, Dr. Conrad. Okay. Yes, good. Abdurrahman. Okay. Good. That's good. Okay, that's fine. Yes. Any other questions, or we shall give you time to extend 4 minutes to extend your or to improve your circulation before the ground round. Anyhow, as long as there's no questions, I will conclude, and I will thank you very much and enjoy your ground round. Thank you.